Today I would like to talk about the clavicle fractures. And first of all, I want to thank you, Professor Dr. Mohammed Lashab, for this nice invitation and for giving me this nice talk. I would like to thank Dr. Mohammed Gouda and Dr. Hossam for this nice complimentary words from them, and for the very nice presentation from Professor Dr. Ahmed Abdessamia. The clavicle fractures, they are one of the most fractures in the upper limb and mainly in the shoulder joint. The incidence itself is not to underestimate. It's about 44 to 66% of all shoulder fractures, and it's very common in adults and in children too. The mechanism of injury is like almost all upper limb fractures, either fall on outstretching hand or falling on the shoulder itself, or a direct blow on the shoulder. And nowadays we see car accidents and motorcycle accidents and bike accidents with many clavicular injuries. First of all is the clinical assessment. The patient comes, so we start with the inspection. We see asymmetry between the two other shoulders. That's why you need to expose the whole upper body to examine both shoulders. You can see ecchymosis, maybe you can see some swelling and hematome and skin tinting. Then you have to palpate the patient systematically. You will feel maybe crepitus, maybe instability, and you need to palpate the distal and the radial ulnar pulses. And don't forget to examine the radial and the medial and ulnar nerve, axillary nerve distributions. However, the clavicle fractures are very common, but they are not rarely associated with other fractures. So you need to exclude other associated injuries like scapular fractures, rib fractures. You need to palpate the AC joint and the sternoclavicular joint and check for pneumothorax and brachial plexus injury. So we start with the imaging. We make clavicular view and a shoulder view, because maybe he has a head fracture of the humerus too. You need to sometimes to make an X-ray of the other shoulder, of the contralateral shoulder, or a chest or the thorax AP view to exclude pneumothorax. Sometimes we need CT scans to diagnose the clavicle fractures or to exclude sternoclavicular dislocations and AC joint dislocation. So if you make an X-ray, you will see one of the three images, either a medial third of the clavicle fracture, a lateral third of the clavicle fracture, or a medial third, which is very rare to see a medial third fracture. In the literature, there are too many classifications for the clavicle fractures. There is Allman, Neer, Robinson, and Gray classifications. And maybe from the principle, they are almost the same. For example, Allman classified the clavicle into three different groups: middle, medial, and lateral. Robinson, maybe he said, I will make it to the same, medial, middle, and lateral, but he classified it to medial fifth, lateral fifth, and middle 3/5. Neer classified it almost like Allman, but he made more classification for the lateral third of the clavicular fractures. And Craig is almost same as Robinson. So if we go to Neer's classification of the lateral third of the fracture, he classified the lateral clavicular fracture into 5 parts. The first one was lateral to the conoid and trapezoid ligaments, to the CC ligaments, and it's apparently stable. The type 2A is lateral or medial to the coracoclavicular ligaments, and it's unstable, and the AC joint is slightly affected. Type 2B is through the coracoclavicular ligament, and it's one part of the coracoclavicular ligament, the conoid part, is injured. Type 3 is a small part of the lateral clavicle, and the coracoclavicular ligaments are stable, the AC joint is stable. That's why we tend to, for the conservative treatment in type 1 and type 3. Type 4 is mainly for children with open epiphysis and physis, and type 5 is multi-fragmental fracture of the lateral clavicle. First of all, the first aid. On the injury scene, maybe you can do some small measures which will help the patient. First of all, the immobilization in a small sling to comfort the pain. Nowadays, it's not advised to give non-steroidal anti-inflammatory drugs because they have an anti-inflammatory effect and they have been associated with higher rates of non-union. Maybe for the younger doctors, if you see if the skin is tinted or the fracture is open, you don't make a stitch, or you don't try to make a reduction of the clavicle. It's an urgent indication for an operative treatment. The open fractures, these must be treated between 24 to 72 hours of the injury, and he has to take for almost 2 to 3 days intravenous antibiotics, and you have to ask about the tetanus prophylaxis. Now there's a small image for the first aid immobilization. Is like a triangular piece of cloth. It has 2 ends and a pointer. You just put one end on the contralateral shoulder, and you pull the other end to the injured shoulder, and you make a tie on the back of the head, and make a small tent of the last point of the cloth, and you can fix it with a staple or something. So that will be a very good way to immobilize the shoulder till the patient goes to the hospital. I will start with the most common fracture of the clavicular fractures, which is the middle third of the clavicular fractures, which have been very often conservatively treated, but the evidence-based recommendation has changed with time. First of all, they said the non-operative management that has been recommended for the dislocated or the mildly dislocated middle third fractures, and it was a non-union rate of between 0.03% to 6.2%. However, in the recent literature, the non-union rate for the displaced fracture was high as 26%. And in comparison to the treated ones with operations, they had 1% of non-union. However, the indications for non-operative treatment, it will, if you have an intact skin and non-displaced fractures, no comminuted area, and more than 50% contact of bone. If you want to make a conservative treatment, in the literature, there are not, some people like to make a figure of 8 bandage or an arm sling. Some people like to make both of them. There is no big difference between a figure of 8 bandage and a sling. You can do it for 2 and 6 weeks, and you start after 3 weeks. And if you make your radiological x-rays after 2-3 weeks, the patient can start to make pendle exercises. However, after healing, the patient needs to make stretching exercises to regain the range of motion and avoid contacts of sports for minimum 4 to 5 months. So we can go now to the operative treatment of the middle third of the clavicular fractures. The indications are clear for most of us. For the comminuted fractures, maybe fractures with 100% displacement, open fractures, floating shoulders, neurovascular vascular involvement, and most importantly, significant shortening more than 2 centimeters and a vertical fragment. For the operative treatment, we can start with the plate and screws. In the market, there are too many shapes and too many different plates. You can see use the conventional plate or reconstruction plate, and there is the pre-contour plates, anatomical plates, and they are in locking or non-locking systems available. However, there is advantages, there are very good advantages of the plate screws. It's like it provides rigid fixation, the rotational control of the fraction is very good controlled, and there's ability for cortical compression. However, the disadvantages, you might damage the surrounding neurovascular, more structures, you have more stripping for the soft tissue, and sometimes it needs you need to remove the plate and screws after minimum 1 year. Like I said, there is in the market the non-locking plates or the locking plates. You can use according to the fracture type, to the bone type. The non-locking plates maybe are used for young patients with very good bone opposition, no comminution. The locking plates are stiffer constructs, and they are more indicated with patients with osteoporotic bone and severely comminuted fractures. Another point to put in consideration while fixing the clavicle fracture is the plate positioning. The standard or the most common type to position the plate, as we all know, is the superior position of the plate and putting some interfragmentary screws. However, it has some disadvantages, although in the advantage we are putting your plate on the tension side of the fracture, so it's more construct. However, disadvantage, the plate is more prominent and with little software coverage. The screw trajectories aimed towards neurovascular structure and the length of the screws are not very long. And we have seen some patients who develop iatrogenic pneumothorax because of the drilling or a long displacement of screws. The other way of positioning the plates in the clavicle fractures is the anterior inferior part. So you make your position of the bone, you put the plate from anterior inferior. It's more covered with soft tissue. You have safer screw trajectory. You have less prominent hardware. You are far away from the important structures like the lung, for example. And sometimes you don't need to have a regular removal of the hardware. And the most recent biomechanical studies have shown that an anterior inferior plate placement leads to greater resistance to cantilever bending. Or sometimes you need to make a combination of both. It depends on the fracture pattern, it depends on the bone quality too. Another type of fixation is the intermedullary fixation. However, in the literature, there was differences between intermedullary fixation and plate and screws. And you have, logically, you have in the intermedullary fixation, lower rate of refracture. You have less damage to the supraclavicular nerves, and it's minimal invasive. So it's optimal if the skin conditions are not really good. In the literature at the beginning, there was really encouragement to do the intermedullary fixation with almost 100% rates of success. Maybe in the 70s using the Knowles pin, and in the 80s using any type of intermedullary fixation. They said it's a very good way to fix the clavicle. However, in the recent literature, they started to develop some or to detect some complications. and maybe it was small complications like superficial infections. However, in the last systemic review in 2012, they said that the outcomes and the complications rate are almost the same between intermedullary fixation and plate and screws. So in that way, I would say it's for patient condition, maybe soft tissue condition, and for the surgeon's decision itself. So the types of intermedullary fixation may be K-wires, maybe the Knowles pin, or an intramedullary nail. Now we can shift to the treatment of the second common clavicle fracture, which these times are seen too much. It's the lateral clavicular fractures. You can treat it non-operatively, like I said, in near type 1 and type 3, where the coraco-clavicular ligaments are stable, they are not torn, and the fracture doesn't look comminuted, or if the displacement less than 5 millimeter. You make a sling immobilization for 2 weeks, and you start the shoulder motion as soon as the pain starts to improve. Like I said, the results of the management of the lateral clavicular fractures have many key factors. It's not only the fracture displacement, it's how you have to assess and you look for the involvement of the coraco-clavicular ligament, as it's very important for the stability of the fracture and the stability of the fixation itself. The indications for the lateral clavicular fracture fixation: it may open or impending open fractures, subclavian artery or vein injury, floating shoulder, near type 2A, 2B, and 5, brachial plexus injury, closed head injury and seizure patients, and polytrauma patients. You need to fix the lateral clavicle. The operative way of the clavicle, it depends on the fracture pattern and the way of the fixation itself, and on the stability of the coraco-clavicular ligament. First of all, you can do a hook plate, like an AC joint bridging method. It's a very good method to fix the lateral third of the fracture, but you need to remove the plate after 3 months, and the patient is not allowed to move his shoulder over 90 degrees abduction or over the horizontal line till the plate is removed. Maybe you can do an isolated osteosynthesis with plate and screws, like a T-plate or the pre-contour plate. But like I said, you have to always check the integrity of the coraco-clavicular ligament. And here is a small example for only addressing the bony injury and not addressing the soft tissue injury. And you see the colleague had a very good construction of the bone. The lateral clavicle is very good fixed with plate and screws, but the AC joint is totally dislocated. So you have to address the coraco-clavicular injury too. And sometimes you need to do both, the fixation of the bone itself and reconstruction of the coraco-clavicular ligament with, for example, a tightrope technique. Now, the last part of the presentation today is about the treatment of the medial clavicular fractures. They are a very rare injury. You can see them maybe in 2 to 3% of all clavicular fractures. All the fractures have been managed conservatively, even they are very highly displaced. You have a union rate of almost 92% and a non-union rate of 8% when they are treated conservatively. However, if there's an indication to operate the very rare condition of that fracture, so you have to make an open reduction and internal fixation of the medial clavicle. For example, open injuries, maybe neurovascular compromise, overlying skin compromise. Here, for example, that's a type or a very clever way to fix the medial clavicular injuries. That's a standard distal or lateral clavicle plate. It's a locking plate, and the colleague used the ipsilateral side and he put it on the other side of the clavicle. So he just made a very nice trick to use the plate of the lateral clavicle and put it on the medial clavicular side, but in an opposite way. Maybe you can use a conventional plate and screws. It depends on the fracture type and it depends on the skin quality. The take-home message today, I would like, before I finish my presentation, just to give some key points for this presentation. Clavicle fractures are one of the most common shoulder injury, and they're not always as isolated injury. For the non-operative treatment of displaced middle third fracture in the recent literature have a non-union rate of 26%. You need to choose your implant and the position of the plating in cases of middle third fractures very carefully, and you have to know what are the type of plates and for which type of fractures and bones. There was a dilemma between the close reduction and internal fixation and open reduction and internal fixation in the middle third of the clavicular fractures, but in the recent literature it's almost same results, so it depends on the surgeon's decision. In the lateral third of the fractures, don't forget to consider the coracoclavicular ligament stability. The medial third fractures are rarely indicated for the surgical treatment, but if they are indicated, it can be easily done with conventional plates or that trick to use the lateral clavicular plate and do it upside or in other way around. And would like to thank you for your listening and for your attentions.
Thank you so much, Dr. Ramy, for this very interesting talk. My dear friend, Dr. Ramy Elzahar, محاضرة من العيار الألماني الثقيل يا دكتور رامي.
سبحان ربنا يخلي حضرتك. أنا يعني
حسام معانا؟
شكرا يا دكتور رامي.
يا دكتور حسام.
سامعني كده كويس يا دكتور محمد؟
يا حبيبي.
دكتور رامي، هو في سؤال بيقول what is the best approach for clavicle, superior or anterior?
For me myself, I would like to make an incision from medial to lateral on the borders of the clavicle. Some colleagues, maybe for cosmetic regions or maybe for females, they like to make a vertical incision because it's better when they wear their bra or maybe their swimming suit. They can cover the scars with the swimming suit. But I would like to make, or I always use the horizontal incision along the clavicular border. It's very good, and I can see my my fracture. I can make a reposition very good, and I can make a cosmetic suture for the skin, and I don't like to do the longitudinal incisions for the clavicle.
Dr. Ramy, may I ask a question, please?
Please.
May you stop the first? May you stop the screen sharing, Dr. Ramy?
Yes. Okay. Sorry.
Okay.
Yes. Yeah, I stopped it. Yes.
What about the clavicular non-union, Dr. Ramy?
We saw some clavicular non-union, and sometimes you need to make a revision and replating, and we saw sometimes plate failure.
Yeah. Do you graft it?
I grafted, yes. We remove the pseudoarthrosis and we put a graft, but it depends if it's atrophic non-union, so I have to to put a plated graft, but it's always, if it's about implant failure and it's a non-atrophic non-union, so the rigid fixation will be enough. And sometimes we revised clavicle fractures and we made the superior and anterior placement, double plating.
Yes, my dear friend, Dr. Ramy, if I have a non-symptomatizing clavicular non-union, I have to interfere?
No.
Yeah.
If you don't have, and that's what we see sometimes in the medial clavicle fractures, that the medial clavicle fracture, they are not radiologically having a sound union, but the patient have no problem. So as long as the patient has no problem and he has a good range of motion and he can do his daily activities, even if he does some sport activities with pseudo arthrosis, and he doesn't have any problems or pain or discomfort.
Yeah.
So why do you interfere? We interfere only when there is a symptomatic non-union.
You are absolutely right. Dr. Hassam, we have other questions, sir?
Dr. Ramy, في سؤال بيقول in young patients we usually have a low solution for to do operation. Can you give us your experience about this, please?
I didn't hear the question very well. لا الصوت مش كويس.
طب اوكي انا معاك يا دكتور رامي. In young patients we usually have low threshold to do operations. Open reduction and internal fixation. Can you give us your experience about these, please, in non-absolute indications?
Well, the indications are very clear. If you have comminuted fracture, if you have a displacement, if you have a bone overlap, so it will heal. And there was always in the old literature, they always said clavicle fractures always heal. But what if they heal? What if there is a malunion? If there is more tension of the AC joint, if there is more tension of the coracoclavicular ligament, and we're talking about a young patient, maybe he wants to play push-ups, maybe he wants to play tennis, maybe he's a basketball player or a handball player. I think with a malunion of the clavicle, he would have problems doing overhead activities.
Yes. We have another question, Dr. Ramy, from our dear colleague, Dr. Ibrahim Kamar from Ireland. He thank you for this comprehensive presentation. Do you prefer hook plate over the new anatomical plate, as it is more stable construct, even if it may need to be removed for the shoulder pain and impingement symptoms?
Well, it depends. Like I said, it depends on the fracture itself. Sometimes we have a very lateral fractures, and you cannot fix it with a normal plate, and you don't have a place for one or two screws. So you have to make a bridging, the bridging principle itself. I read in some literature, some people make a plate from the clavicle to the acromion, acromioclavicular plate, so just bridging the whole thing. But you have to choose the best construct for the fracture that you're having. I can't say all the fractures should have this, or I prefer this, or I prefer that. It depends on the fracture itself. If I have a good bone construct, if I have a good bone piece where I can put one screw or something, and okay, I will not make a hook plate, because I know that I'm going through the AC joint. However, the hook plate, the hook itself, it appears as if it's inside the AC joint. It's from the posterior side of the joint. So it's not affecting the AC joint. He's not having post-operative arthritis or something like that. But before I go to the operation with the hook plate, I say the patient that this kind of plates needs to be removed. It's not an option to leave the plate. However, as long as he has the plate in his shoulder, he cannot move the shoulder over the 90 degrees or over the horizontal line. So he would be always having impingement or pain in the shoulder as long as he's having the hook plate.
Yeah. We have a question from Dr. Ala Razin. What do you mean by vertical incision? Do you mean like MIPO, sir?
I mean exactly like anterior incision from above to now.
Yeah. And another question is: the figure of 8 bandage still valid for conservative treatment?
Yes, we have in my emergency room we have both. We have both. It sometimes is about the patient's toleration, and it was maybe for some colleagues or maybe for myself before I went deep in the literature. It was just like the era of the figure of 8. It looks better. You can move your elbow. It looks more free. Maybe cosmetically looks better, but in the literature, it's the same. If the patient is tolerating the figure of 8, okay, he can use it. He has the advantages of moving his elbows and moving his hand. However, in a sling, he can do that and make a passive and active movement of the elbow. And some colleagues use both.
Yes. Another question is: there is special treatment indication choices consideration for athletes?
For athletes, of course, yeah, like I said, you need to look at the AC joint, for example. You need to look at the coracoclavicular joint. It needs to be reconstructed because sometimes you use the hook plate maybe in a more dependent way. That we say, okay, I will put a hook plate. I'm stabilizing the AC joint, even if the coracoclavicular ligament is torn. And then after removing the plate, or sometimes you have a non-union, or you have an implant failure, because the plate itself will not fix both problems, the software and the bony problems. So I would like, especially for the professional athletes, to address the soft tissue injuries too, because I can't put him in a sling for 3 months or something, or I can't leave him with 20 degrees of loss of motion. So he needs to have a full range of motion and a pain-free shoulder.
Yeah, you're absolutely right. The last question: what procedure do you prefer in distal clavicular non-union?
Well, in distal clavicular non-union, it's a very hard situation. They are maybe, it depends on the age of the patient. It depends on the bone quality. Sometimes if it's an old patient and he doesn't have a high expectations, and maybe it's the left shoulder, and he's over 75 or 80 years old, and he's not doing too many things with the shoulder, maybe you can make a distal clavicular excision. Or maybe if he's a young patient and active and wants to have a fully functioning shoulder, and it's his demanding shoulder, you can make some kind of maybe grafting and plate and screws, or some procedures like Weaver-Dunn procedure.